In terms of a medical history, in primary care, we hope we know the patient already. If you go to an emergency department with blood in your urine and they don't know anything about you, they've got to start from scratch. In many communities, if you have a relationship with your GP, they've actually got maybe 5, 10, 15, 20 years of medical history on you already, and those things are important to know. So the age of the patient is very important because the likely cause of the haematuria is very much affected by age. But the association of other symptoms, particularly any irritation when passing urine or any discharge associated with passing urine from the urethra is really important. So those things are critical. Asking the patient about whether they've got signs of bruising or bleeding or enlarged lymph nodes anywhere else is important. General questions around their health. How have they been feeling? Have they had fever? Have they had any weight loss? Asking about whether they've got any of the sorts of pains that we talked about earlier, things like low back pain or pelvic pain in particular. But again, bearing in mind that those are very non-specific symptoms, and the vast majority of people who have those symptoms wouldn't have bladder cancer. Two important things to think about, or three really, and to include are the patient a smoker? And again, if you know the patient well, you probably have that information already. There's certainly evidence that smoking increases the risk of bladder cancer in the population generally. Secondly, have they worked with particular substances that can increase the risk of bladder cancers? And there's a number of chemical substances, particularly those that are used in some of the dye and painting industries, that we know if inhaled and ingested can increase the risk of bladder cancer. And that's why if somebody's working in those industries, they'll usually be encouraged to wear sort of fairly sophisticated ventilator masks. And the third is there any particular family history of bladder cancer? There's not a hugely increased risk of bladder cancer if you do have a family member, but there is an increased risk. So again, if there's been a family history, we would like to know that. The patient will receive a physical examination when they see the GP, and I'm talking about the GP consultation here. The details of that examination will depend on the symptoms that the patient presents with. And remember, in general practice, the patient will often present with 2 or 3 different things. So they may have a sore throat at the same time, and they may mention, oh, last week I passed some urine, some blood in my urine, and it settled down. But in terms of the specific examination you might do to investigate haematuria, an abdominal examination, which means the patient's got to lie down, expose their abdominal area, and the doctor will want to palpate it. Not a particularly high yield examination in most patients, but certainly will pick up any sort of large lumps or masses or tumours that might be there. You may choose to do a digital rectal examination of the patient, and certainly if you're concerned about prostate causes of blood in the urine or discomfort in the pelvis, you would do that examination. But that also depends on sort of patient acceptance and patient comfort of that particular examination. The most important one to do is to actually examine the urine. If somebody has blood in your urine, you need to send the urine away. You can do a dipstick test in your surgery while the patient's there with you to see if there's any sign of infection there. If they've got macroscopic haematuria, they've got blood there. Although interestingly, every now and then, if it's say something like beetroot and you think it's blood and you do the test and it comes back sort of negative for blood, that can help you with your diagnosis. But you'll also send some of the urine specimens away to see if there's any sign of abnormal cells there or infection, to do an actual culture for infection. And there are 3 sort of broad groups of investigations that I might send the patient away for. The first would be specific examination of the urine, and it's a routine way of investigating blood in the urine would be to ask the patient to submit a specimen on 3 consecutive days to the laboratory. Some laboratories now only do it on 2 consecutive days, but traditionally it's been 3, where they look for, among other things, abnormal tumour cells in the urine specimen, but also can check for other signs of infection or inflammation as well. You may want to do some other blood tests associated with that, looking for signs of inflammation, infection, anemia. If the patient's reported very heavy blood flow, they may actually be quite anemic as well. So at the same time they're attending laboratory for their urine sample, they would be having those relevant blood tests done as well, checking their clotting factors and things like that. And then the third group of investigations are imaging investigations. depending on your level of concern. So again, if I had a young woman who this appeared to be some bleeding associated with a urinary tract infection, I probably wouldn't send her for imaging until I saw how she responded to treatment for the infection. But if I was concerned that bladder cancer might be a significant risk for a particular patient, in an older patient for instance, I would want to know what the structure of their genitourinary tract was like, and there are a number of imaging investigations that can help with that. The simplest, least invasive one is ultrasound, which is a sound wave picture essentially of the kidney, the bladder, the prostate, and that will tell us some information around sort of any gross pathology, if there's any sort of big masses in the kidneys, if there's any blockages in the various tubes that lead into or out of the bladder, but it won't give us fine detail about, for instance, a small lesion that might be in the bladder. If you're looking for those sorts of higher resolution imaging, probably the commonest and most detailed one is what we call a CT examination, which is essentially a form of X-ray, but where you give the patient a dye solution as well, an injected dye solution which is excreted through the kidneys into the bladder, and you can really outline with quite a high degree of detail the internal workings of kidney, ureter, bladder, and see how things are going. There are a number of other imaging tests. You can do an MRI, which is another form of sophisticated imaging. You can do bone scans. Usually if I'm thinking about those sorts of investigations, I'm either talking to the radiologist, because the optimal form of imaging does change over time. So rather than me trying to remember what the best one is, talking to the radiologist about what they think would be most useful. But also by this stage I've often engaged with a urologist, a specialist in bladder cancer and other genitourinary problems, and allow them some input into what they think is the most appropriate imaging. All of the investigations that I've mentioned up to this point, and including the consultation with a general practitioner, have a rebate associated with them from our Medicare system. The exception to that can be the MRI. Sometimes there'll be a rebate available, but depending on whether how the machine is registered. But virtually everything we've talked about is covered under our Medicare National Health Insurance System. Private health insurance covers mostly hospital-based experiences, the way the legislation around private health insurance works in Australia. It comes as a surprise to many people that private health insurance that they get encouraged to take out actually doesn't cover a lot of the out-of-pocket costs from seeing consultants, doctors and consultants in the community, and some of those investigation costs as well. Certainly in terms of their hospital-based costs, it depends on the level of private health insurance that they've got. But again, they're the sorts of things, if they are going to have any hospital-based services done, they need to make sure that the hospital discloses at the beginning, what those likely costs are. Again, we have a free public health hospital system here in Australia, and the sorts of services that might be required for people when you're investigating hematuria or treating bladder cancer are all available within the public hospital system. But many patients will choose to use the private system because for convenience and the choice of the doctors that they're treating them. I think when I see the patient and the system that we tend to use in health generally, both in general practice and in consultant practice, is what we call a probability diagnosis system. So if a young woman comes in who's got pain passing urine and some blood in her urine, probability diagnosis is a urinary tract infection. So we would be investigating and treating along those lines. But if at any stage the patient wasn't responding, or we got abnormal findings in terms of our investigations, we would have to consider less likely diagnosis, such as bladder cancer. For an older patient who doesn't have other symptoms, who hasn't had any changes in their urine pattern and has suddenly developed hematuria, the probability diagnosis might be that this could be an early bladder cancer or a bladder cancer. So my investigations and management would be focused on that. Does it matter if I've got a 25-year-old woman who seems like she has a urinary tract infection and ultimately proves to be, a very unusual case of early onset bladder cancer? Does it matter that I didn't pick that up at the first consultation? No, it doesn't, provided that I make sure that ultimately, over the next few weeks, we find out what is causing her bleeding and manage it effectively. I refer to it as an open door or a closed door approach by the doctor, and it's a useful concept, I think, for patients. If I say to this young woman, look, there's absolutely no chance you have a bladder cancer, it's an infection, just keep taking these antibiotics till it goes away, thank you, end of consultation. That's what I call a closed door consultation, because for the patient to come back to me and challenge me and say, look, I'm not really sure that it is an infection, or I've still got the bleeding and whatever, they actually have to challenge me. If, on the other hand, I say, look, this has all of the characteristics of a urinary tract infection, you fit the profile, everything on my examination and investigation fits that, we're going to treat it at that. But if these symptoms don't settle down or don't respond within X amount of time, or if you have any concerns, make sure you come back and discuss them with me. That's what I call an open door policy. That allows me not to over-investigate a patient who's not likely to need those investigations, but it leaves the avenue open for further investigation, follow-up if we need to. And the patient doesn't have to challenge me coming back. I've invited them to come back if their symptoms don't settle. I have absolutely no concerns about patients seeking second opinions. I guess the reason for seeking a second opinion is the important thing. If a patient doesn't have confidence in what their doctor, either the GP or the specialist doctor, has said to them, that's a concern. And it would be good if the patient felt comfortable to raise those concerns and lack of confidence with the doctor themselves. If, on the other hand, the patient's being faced with a number of complex choices around options for surgery, then it's perfectly reasonable to see what another good consultant would advise. So if we reach a situation where a patient has a diagnosis of bladder cancer, that's when, as a GP, I would step back in terms of making management and treatment decisions specifically for the bladder cancer and be guided by what the consultant urologist or oncologist, the cancer specialist, the urologist may be working with. The GP still has a role, because remember, many patients, particularly if they're older patients who have bladder cancer, have a lot of other what we call comorbidities. So when you get to my age, you don't just have your bladder cancer, you might have arthritis, you might have hypertension or high blood pressure, you might have diabetes, and how the management of those conditions is affected by the treatment of the bladder cancer is very important. So the GP is an important part of that multidisciplinary team as well.